So, dear colleagues, it's my pleasure really to report from Paderborn in Germany about electrical storm, and I'm very happy to participate in this very interesting meeting and to be with friends and Luis Aguinaga. We are performing a couple of different other aspects right now and writing papers, etc. So I'm very happy that I could be invited. The next slide shows my disclosures. So electrical storm. Why do we talk about electrical storm? And this is a typical picture coming from the guidelines that a patient has repetitive episodes of high run VT episodes or ventricular fibrillation. And of course, this is alarming and the mortality rate is extremely high. So the question is, what is the current status? And what I'd like to do is to focus on a couple new aspects, probably also for pharmaceutical therapy, to start how we can be better or become better in therapy of these patients. Next slide. So the overall mortality is really high, and you can see that regardless of the underlying pathology with ischemic cardiomyopathy or a dilative cardiomyopathy, patients with electrical storm have a substantially higher mortality rate in comparison to patients without electrical storm. So this is actually true then for all the different cardiomyopathies, because ischemic heart disease or dilative is not the only type of cardiomyopathy. It's also hypertrophic cardiomyopathy and others, but the results, the horrible results, are always the same. The next slide. So in the current definition, usually we use more than 3 episodes within 24 hours, but this analysis really points out that the definition we currently use is not very helpful, because you could see that even after 2 episodes, the mortality increases substantially. But you can also see if you have 2 episodes, even within 3 days, or within a longer time frame of 30 or 90 days, this is also relevant. So the question is really the definition we are using right now, requiring 3 episodes within 1 day, really appropriate, because the same risk applies also to patients who have 3 episodes of VT, VF, or even 2 within a much longer time frame. So probably the likelihood to start therapy should be much more aggressive, because we need probably to discuss the current definition of electrical storm. The next slide, please. So the substrate, of course, is of importance, but I will also focus a bit on autonomic nervous system and also on triggers. And I think this makes the whole situation very complicated. So in the next slide shows that the pathophysiology now is also quite well described on a molecular basis. So on a molecular basis, we know that calcium overload within the cell has a substantial impact, and the calmodulin protein kinase is important, and this is one of the potential targets, as well as the sympathetic nervous system. So the question is, do we have new approaches really, if we could reduce the number of delayed or early after depolarization triggering or perpetuating the electrical storm in this scenario? So of course, we know that sedation may help, but what about these molecular pathways? And the next slide summarizes some interesting results. I do not want to go into detail, but we do know that SGLT2 inhibitors, empagliflozin, dapagliflozin, actually do have an effect on the calcium calmodulin dependent protein kinase 2. So the large phase 3 trials have actually provided evidence that these inhibitors, right now widely used in cardiology, do have antiarrhythmic potential. And I would at least bring up the hypothesis that within electrical storm, due to the specific action on calmodulin dependent protein kinase, there should be a beneficial effect. The next slide. And similarly, there are also now in the development other calmodulin protein kinase 2 inhibitors like hesperidin. And there are also now a couple of new targets and drugs which are in the process of development to inhibit, in particular, the calmodulin-dependent protein kinase 2, and we have to see if we can come up with new therapeutic agents. So on the other hand, next to this protein kinase, sympathetic nervous system is of importance. So the next slide summarizes all the effect known that we have afferent and efferent fibers, and all these are linked in the ganglionate plexus and also the ganglion stellatum, which appears to be of major importance because within this ganglion, multiple pathways are actually synchronized, and we can target the afferent type of nervous cells as well as the efferent nervous cells. So this appears still a very important target to suppress electrical storm. So next slide. So overall, again, it's of course reprogramming of device, because usually these patients do have a device already. We know that catheter ablation is a very prominent figure in this place and scenario, but also the sympathetic nervous system and potentially antiarrhythmic drugs. So if we go now to the guidelines on the next slide, we can see that this is integrated. So if a patient comes in with electrical storm, of course, you have to interrogate the device and you have to see if you can adapt the device, because sometimes you may see supraventricular tachycardias, and then, of course, you need to reprogram the defibrillator to terminate this. On the other hand, of course, to reduce the impact of the nervous system to the heart is of substantial importance, because the sympathetic nervous system triggers also the calmodulin dependent protein kinase. So sedation and intubation is a treatment. So of course, and then you have to see what the ventricular arrhythmia looks like, if it's polymorphic or monomorphic, and of course, if the patient is hemodynamic stable or not. So the next slide then goes to the situation where you have a polymorphic ventricular arrhythmia. And of course, you could see if you have an underlying event like STEMI, a myocardial ischemia, that needs to be treated, of course. And you have, with a class 2A indication in these days, also the degree of catheter ablation. And I think we have learned from many trials that after the first episode of VT-VF, you should already, of course, consider, regardless of the underlying cardiomyopathy, catheter ablation. Of course, in patients with dilated cardiomyopathy, you may go epicardially to reach the focus. And then you may actually add other issues like potentially new drugs. However, these have not been integrated here, but there are rare scenarios where you'd use quinidine. Of course, quinidine is usually in many countries not available anymore. So for this reason, of course, the option is not always valid. However, it depends on the primary electrical disease. So catheter ablation or amiodarone, if you do not have a long QT, in combination with a beta blocker, could be a scenario. So the next slide summarizes then the effect if you have monomorphic ventricular tachycardia. So reprogramming and combination of beta blocker and amiodarone is usually the way to go, or of course to catheter ablation if the patient is hemodynamically stable and you can do the intervention without need of support. But in addition, even if the patient is not stable, you can go for catheter ablation. However, you need to have a heart-lung machine or other measures to have the patient hemodynamically stable. So the next slide shows the one of the meta-analysis showing that within electrical storm, catheter ablation is feasible. However, it really depends on the hemodynamic situation. And of course, the recurrence rate varies quite a lot in these smaller studies, from 5% up to 30%, where you have recurrent ICD shocks and a next storm. So for this reason, of course, you cannot really predict the outcome, but catheter ablation definitely is a way to go. And I would personally say, especially in patients with monomorphic VT, this is definitely a candidate which we would actually ablate. On the next slide, you can see just the evidence listed also in the guidelines that, of course, intervention of the sympathetic nervous system as class 1 indication to interfere with this. Then also the use of beta blockers, also in combination with amiodarone. And if the magnesium level is low, you should supplement this. You may need to reprogram, of course, the device, and intubation and deep sedation is always a strategy also to reduce the stress factor by shock application, which then feeds back the sympathetic nervous system and also another events of electrical storm. So the next slide. So what we should do is, if the patient is in electrical storm, it needs to be measured and the hemodynamic situation needs to be addressed, like here. And this is a very nice paper where you can actually see what the parameters are, how to predict hemodynamically stability in these patients. And this is also summarized on the next slide in a table that you can see what the different measurements are. If we go to the next slide, please. That you have target with regard to lactate, we have target levels with regard to blood pressure. So this is something what we use conventionally, of course, in the intensive care unit. But I think the stage at risk beginning, a classic shock situation, deteriorating and extremis is, I think, very helpful for also determine the prognosis of a patient in a current situation. So what about the whole classical scenario, how to do blockade of the stellate ganglion? And this is shown on the next slide. And usually what we do is we do this with our anesthesiologist, usually together, because they are usually experienced, but I think there are also electrophysiologists who are capable of doing it. Usually what we do, we use sonography to have the anatomy of the neck present, and then we locate the ganglion, and we use then classical lidocaine for inhibition of the activity in the ganglion. So the next slide shows acute results, and you can see that before and after that the number of episodes really is reduced substantially. So it's not only about the substrate in the heart, it's really, and I think this is important to address, the combination of the molecular biology in the cell and the sympathetic nervous system. So, and also after the ganglion is knocked out, you see less shocks. So I think this is quite obvious. And if we go to the next slide, you can also see that these results do not depend on the type of cardiomyopathy, and they do not depend on the ejection fraction. So this measure and this procedure really works in the patient with electrical storm, regardless of the underlying pathology. And I think this is very important. So what other types do we have? We do have different cardiomyopathies. We do have electrical diseases, which can actually cause electrical storm to occur. However, we have new aspects, and the next slide shows an interesting finding that there are a couple reports now after Micra implantation. So it's a leadless pacemaker, and the leadless pacemaker per se, by mechanical irritation of the myocardium, can induce electrical storm. But this is an interesting finding where actually the pacemaker itself was not a trigger. It did not induce the electrical storm per se, but it changed electrical activation of the ventricle. And due to the fact, and the next slide, that there was a tissue alterations present already in the left ventricle as well as in the right ventricle, actually the interference between a pacemaker and the scarring in the ventricle induced VT, and catheter ablation of this area actually could stop the electrical storm in this patient. So I think this shows that electrical storm, we have actually new drug targets besides the true and quite well investigated catheter ablation therapy. However, I think we should take into account that the sympathetic nervous system really has a tremendous impact, as well as the calcium calmodulin dependent protein kinase 2, and we do have the SGLT2 inhibitors and potentially new drugs. So the last slide then summarizes these effects. So if someone comes in with an electrical storm, I think the guidelines beautifully summarize what we can do. We need to interrogate a device. We need to adapt the device. We have to make sure that the patient becomes hemodynamically stable. We need to intubate and sedate the patient just to reduce the stress also from new upcoming shocks, which I think is very important. Then, of course, we do have the problem or the potential effect of catheter ablation in polymorphic VT as well as in monomorphic VT. I think in monomorphic VT or in episodes where you have triggering extrasystoles, it's quite intriguing to do a catheter ablation. However, I think the definition of electrical storm is not very appropriate. Probably we have to widen the definition to be more aggressive, even in patient who has more episodes of VT, VF within a month or so. I think that is probably a realistic scenario. And this is also underlined by recent data that we probably should approach the second episode of a VT much faster and more aggressive and probably start after the first. And we do have probably new targets I talked about. And we have summarized many of these aspects in the first ERA white paper, where we actually define knowledge gaps, and probably this is also something to read. So the final slide shows you my hospital back in Paderborn. It would be nice really to come to Argentina probably during the next meeting. So I would be very happy and to do so. And now I'm happy to take your questions. Thank you so much for having me.